I'm Dr. Eickmeyer. I work at KU. I'm a physician in physical medicine and rehabilitation. And I work with a lot of people who've had strokes. I've probably talked to you guys several times at this point. And like Sarah mentioned, we're very open to what topics you want to hear about. I change my talk every year based on what topics people have suggested. And so that is how we came up with this topic this year. So, oh, sorry, you guys can hear me? Okay, great. So we're going to be talking about medications that might help with stroke recovery and some of the sequelae, and just kind of give you some evidence from research that's out there, and then a little bit about what I do and what I recommend. So these were, it's really hard to pare it down because there's a lot of things that can happen after stroke. But when we talk about medications, things that might help, I tried to narrow it down to 4 main topics that we'll go over today. And so those 4 topics are talking a little bit about recovery, but then I'll explain a little bit later that's associated with depression management and a class of medications we call SSRIs. So we'll talk about that first. Then we'll talk a little bit about the symptom of fatigue and other things that might present as fatigue and some of the medications that might help with that. We'll talk about aphasia, and memantine and donepezil are 2 drugs that might help during your aphasia recovery. And then we'll end talking a little bit about spasticity management. And these 3 drugs that are listed here, baclofen, tizanidine, and dantrolene, are 3 of the most commonly used ones. And we'll talk a little bit about other interventions for spasticity. But before we dive into the medications, I just wanted to kind of start with a little bit of a discussion about stroke recovery. And this is something that I spend a decent amount of time talking to people about and sharing information about what happens after a stroke and how do people tend to recover and are there any patterns. And so that I thought would be helpful before we dive into some of the medication management. And so here are just some names of neurologists, researchers, neurophysicists, neuroscientists over the years that have published some pretty important work and have led to our understanding of how people recover after stroke. So first, we're going to talk about Twitchell. So Dr. Twitchell was a neurologist back in the 50s. He worked at Mass General Hospital on the East Coast, and all he did was just document serial neurologic exams on people who'd had a stroke. In the 50s, there wasn't that much rehabilitation or interventions to help people get better. And so he pretty much just kind of wrote down what happened over the first 6 months after a stroke. And so it's really based on his work, his meticulous notes of just documenting people's strength, sensation, and reflexes after a stroke that really led to our understanding of how people get better. And so you'll probably hear doctors in general refer to this work when they'll tell you things like most of the natural stroke recovery happens over the first 3 to 6 months. And that is from Twitchell's work. And so I use it when I'm talking to people who are in rehabilitation because people always want to get better faster and they want to get better in days. And I have to kind of refocus it to say this isn't going to be days or weeks, this is going to be months, at least, if not years, because it takes a long time to get better from a stroke. So what happens, or what Dr. Twitchell documented, was neurologic exams. And so one of the things that he talked about was reflexes. So reflexes are when your doctor comes and takes the reflex hammer and taps on your elbows and your knees and other tendons, and your arm or your leg jumps a little and you might kick out or your arm might move, or you might get what we call clonus, where your limb shakes a little bit and then it takes a couple seconds for it to calm down. And so those are reflexes. And what Dr. Twitchell noticed is that over that first month after a stroke, the reflexes go from really like low to pretty hyperactive by about a month after a stroke. And then after that, those can continue to get even more hyperactive. And so on the side that you had your stroke, your reflexes may always be very hyperactive in the chronic phases after stroke. He also recorded that sensation, or the ability to feel things after stroke, has really variable recovery. And I think a lot of you in the room will recognize this, where sometimes you get numbness after stroke, sometimes you don't get any changes in sensation after stroke, and sometimes you get the combination of numbness and pins and needles pain. And it's really, really variable. And the recovery from that is also really, really variable. And Twitchell was one of the first people that documented that and told other people what we still know today to be true, is that sensation has variable recovery, and there isn't a lot of good information or really interventions that will help you regain your ability to feel in an area that's numb after stroke. He also spent some time discussing what we call spasticity. So spasticity is kind of a broad term that covers muscle stiffness, muscle spasms, kind of jumpy reflexes, and just difficulty in stretching out your limb after stroke. And I'll kind of show you some time points on this, but he really kind of described how that spasticity develops over time and can really become very disabling later on in chronic stroke. The biggest part of his work, though, was focused on motor strength. And this is probably the most exciting part of Twitchell's work, is talking about how people get strength back, motor strength, after a stroke, because it does really recover in a pattern. And the pattern is really predictable. And it's something that I can tell people about and tell them what's coming next. And people really, I think in general, appreciate hearing what's going to happen next, because everything is brand new and scary when you've had a stroke. So the pattern that he discussed or discovered and documented was a couple things. First thing he noted was that movements that were big came back first, and then later on movements that were small were something that happened later in stroke recovery. So being able to kind of, shrug your shoulder or kind of kick your leg out is something that people are able to do first. And the ability to do fine motor movement like write or pick something up very small with your hand is something that happens later, if at all, after a stroke. He also discussed this pattern of proximal to distal recovery in strength, meaning that things that are closer to your body, like your shoulders and your hips, recover first. And then as you get some more strength back, it kind of moves down the arm. So we always tell people first your shoulder, then your elbow, then your wrist, and those pesky fingers are the last thing that are going to come back. And they might not come back all the way, because that's just how it goes with stroke, is that hand is the thing that people really want to come back, but might not always come all the way back. Same thing in the leg. It's hips first, then knees, and then ankles, kind of that last thing. So proximal to distal. The other thing that he discovered for the first time was what he calls synergy patterns. And I'm going to show you a picture of what that looks like. But when he describes synergy, what he basically means is these kind of big gross motor movements where you want to go and reach and pick up a can of Coke, but instead your arm kind of does this funny reflex movement where it draws up and in. And that's a synergy pattern. And then the last thing he discussed was that isolated joint movement. So the ability to open and close your hand, to move a joint without your whole arm pulling up into a pattern, is something that occurs very late in stroke recovery. And so the sooner you get to some of these, smaller movements, distal movements, isolated joint movements, the quicker, the better, the faster your stroke recovery is going to be. And then some people just get stuck too, where they get some movement up in their shoulders and hips and it just doesn't make it all the way down. And that happens as well. And so there's definitely a variety in how people get better, but in general, this is the pattern that we see. So this is the picture of some of those synergy patterns that Twitchell discussed. On the left of the screen is something called flexion synergy. And so the arm is pulled up and out to the side, the elbow is bent, the fingers are closed in a fist. And that is called traditional flexion synergy. So you go to move your arm and it does this instead. There is also something called extension synergy, which is much more rare in the arm, but it would be the same thing. You would go to pick up a can of Coke, but instead your whole arm just extends out in a spasm and you can't really control it. The most typical pattern though is the one in the middle. And this is kind of that typical static pose that you might see in people who've had a stroke with hemiplegia, where the shoulder is bent, the elbow is bent, the hand is kind of in a fist, and it just kind of pulls up into this position. In the beginning, it might have started pulling up in that position when you were coughing or sneezing or rolling in bed or something startled you. Later on in your recovery, it might start pulling up in that position when you walk. And then later on, it just might get stuck in that position. But this is what we were talking about for synergy. So synergy isn't bad. Synergy is just kind of part of the recovery process. And it's kind of like a stage in recovery is kind of how I look at it. These are some pictures of synergy patterns in the leg. So the one on the left is flexion synergy, where the hip, the knee, and the ankle are all flexed and kind of drawn up. This is pretty atypical. We don't see this very often. You might have this, and I guess know that it's just not very common. Again, it's not good or bad. It's just part of recovery. Sometimes our limbs just do these things as we're getting better. The more typical pattern in the leg, though, is what we call extension synergy, where you go to do something. You go to roll in bed or transfer or stand up or take a step, and your whole leg just spasms out into extension. And it makes it really difficult to do those things. But these pictures with the circle are kind of what you typically see with the leg, is that it's stiff, it doesn't really want to bend, your toes don't really want to bend, your knee doesn't really want to bend, and it's just a very stiff limb. And so that is extension synergy. So Brunstrom came along after Twitchell in the 60s, and read Twitchell's work, worked with people who have had strokes, and said, you know what, that is really interesting. I think we can be more specific. And what he did is he took that recovery that Twitchell described, and he just put some numbers on it. That's all he did. He just numbered it 1 through 6, and then he named it after himself. And that's how he got famous. So he basically took Twitchell's work and said, okay, here on the bottom on the x-axis is motor control. So how people recover motor strength, how people move their limbs is kind of on the x-axis, and that happens over time on the bottom here. And then on the y-axis, the up and down line is spasticity. And this basically describes how people recover from stroke. So here's a box that says, okay, you have a stroke right here. And in the beginning, you don't have very much motor control at all. And you also don't really have that much spasticity. And so you're very flaccid. So your limb doesn't move, but it's also not tight. And that's usually what it looks like the first couple of weeks after stroke, or months sometimes. Then as you start to recover, you go into Brunstrom stage 2, which is called synergy, and you get a little spasticity. So you start to get those movements that are kind of big and not really under your control in your arm and leg, where your arm wants to flex and your leg wants to extend. And that's Brunstrom 2. Then as a little bit more time goes on, your spasticity goes up quite a bit, and you get really stiff in the arm and the leg. And things are very hard to stretch out, even when somebody is stretching your limb for you. So that's Brunstrom stage 3. You are getting more movement though, but you're also getting very, very stiff. As you continue to move through time and recovery, you start to get a little movement out of those synergy patterns, meaning maybe you can extend your arm out a little bit better, or maybe you can start to flex your hip and flex your knee when you're trying to sit and the whole thing doesn't stick out and spasm. You also get less spasticity. And so that's really, we call this coming over the hump or over the curve. And that's really when recovery starts to pick up. Brunstrom stage 5 is you start to get a little bit more selective control of movement. And runs from stage 6 is kind of the last stage, which is called isolated or coordinated movement. And we really think about this as being able to use your hand and being able to wiggle your ankle without your whole arm and leg going into spasms or synergy patterns. So this is kind of the typical recovery. Now, not everybody goes 1 through 6 in this order. Not everybody makes it to 6. Some people get stuck along the way. Sometimes you kind of make it through to a stage and then you go backwards. So it definitely is not, it doesn't describe how everybody makes it all the way through. But in general, this is kind of the pattern. I will say that a lot of people get stuck at stage 3 because their spasticity is really bad. And that is the medical reason why we treat spasticity, because we think if we can treat spasticity and get it to go down, you'll actually get some more movement underneath there. We're not able to see it because your spasticity is so severe. So then the next person came along in the 70s, and this was Eickmeyer. And so Eickmeyer basically read Twitchell's work and read Brenstrom's work and said, you know what, I can do even better. I'm going to turn that into a scale. And so he took Brenstrom's 6 stages and he turned it into a point system of 100 points. He gave people 66 possible points for movements in their arm and 34 possible points in their leg, add that up to 100. Named him after himself and published it, and that's how he got famous. So what the Eickmeyer scale does is you can go through it with a physical therapist or an occupational therapist, and you get points for different movements that you can do, and it describes kind of a raw ability of the hemiplegic side and the level of your impairment. And so we actually use Eickmeyer in research to describe where people are and what their impairment is, and to see if any of our rehabilitation interventions are helpful. So we actually still use Eickmeyer today. So this is kind of a really busy slide with really small words, and I don't expect you to read all of them, but I think it's kind of nice. I liked how they basically took these 3 historical researchers and put them together and showed how each work built upon the other, and how as we went from the 50s to the 60s to the 70s, we just got more detailed in how we described stroke recovery until we got all the way up to the Eickmeyer scale. So after the 70s, there wasn't a lot of activity in stroke recovery rehabilitation work for a while. And then in the early 2000s, Dr. Taub, who's a researcher, started to publish on some work that he was doing with monkeys. And what he was doing was he was giving monkeys a stroke in their brain, and then they had one side that was hemiplegic. And then what he did was he put the little monkeys in a vest, and he put the vest over their good arm. And so what he did is he restrained the good arm and forced them to use their hemiplegic arm. And what he found was in monkeys that he gave a stroke, if he put them in a vest and forced them to use their hemiplegic arm, which is like sometimes called forced use or sometimes just called exercise, those monkeys actually had a better recovery after their stroke, compared to a group in which they did not wear the vest, and they basically learned to not use their hemiplegic arm. And this was called a constraint. And so it's kind of confusing to describe, but basically what he did really revolutionized the field of stroke rehabilitation, research, and recovery, because it basically said after you have a stroke, you shouldn't just ignore the hemiplegic arm. You should try to figure out how to use it and how to use it in therapy and how to make yourself use it, even if it means putting a mitten on the other side so you don't use the good side. So this was really revolutionary in the early 2000s and started a whole bunch of different types of therapy that you may have even seen in your own stroke recovery process, including a process called constraint-induced movement therapy, where they will still therapists will put a mitten on the hand that still works well and make you use your hemiplegic side for several hours a day. And that all came from the research of Dr. Taub. So then Dr. Nudo, who's a researcher in our department here at University of Kansas, he took that work of Dr. Taub, and what he did is he looked at what that did to the brain. And so he has some really interesting techniques where he can actually map out on monkeys' brains what is going on, how monkeys are recovering from strokes, and does that map change if you do more exercise and if you make monkeys use their hemiplegic side. And so basically what he found over several years was that rehabilitation really does change the motor map in the brain. So what you do after your stroke matters. If you exercise and force yourself to use that hemiplegic side, you can actually increase the map in the brain of that part of the body. And so that is shown in this picture on the left. So on the left, there is a map of a monkey's brain. The blue represents elbow and shoulder, so elbow shoulder movement in the brain. The red represents hand, and the part that represents hand is where they had the stroke. So these dotted lines here is where they gave the monkeys the stroke. And so if you follow the arrow down to the bottom right, these are the monkeys that got the rehab. And over time, you can see this dark gray spot on the bottom is where that stroke was. And after the stroke is there, you can't do anything about it. It's just the stroke. It is the stroke. It's the tissue in your brain that has died. But if you do intensive rehab, you can change the map. And other areas in your brain, like up here, that didn't used to participate in hand function, now can do hand function. And so that is the idea that exercise and rehabilitation increases the map in your brain after a stroke. Likewise, if you don't do rehab, so no rehab over here you can see how here's that gray stroke, the chronic area that isn't really going to change. And if you don't use that side, that area for hand gets smaller. So if you learn to not use that limb, you're basically over time going to lose that representation in the brain, and that area for hand will get smaller. And this has been done in monkeys. This has been repeated and found to be true in humans, although we don't map human brains quite the same way we do monkey brains. But it all kind of goes into our current understanding of how rehabilitation helps people recover from stroke. So the current understanding of all of that, and that's a lot, is this concept called neuroplasticity. And so neuro means, neural like brain, and plasticity or plastic basically means change. And the old thought, maybe before the 2000s, was that after you have an injury to your brain, like a stroke or a brain injury, that's kind of it. Nothing happens. You're kind of done. And the new understanding is that's not true at all. The brain can recover. The brain can change. What you need to do is to harness that ability of the brain to change and combine it with therapy and exercise. And that will really help you to recover your function. And so this is a theoretical picture. On the bottom, it shows up to 14 weeks. I don't think we actually know what the window is, but in this model, they suggested that the first 6 weeks after stroke, the brain is probably the most plastic. So you can see the red line here is function, and this is all very theoretical, but you're imagining you're going along at your typical normal level of function, and then you have a stroke. And so your function goes way down because you just had a stroke. Within those first 6 weeks, you do regain function and your curve goes up. And the thought is that there is this sensitive period in the blue here that after you have a stroke or a brain injury, there's probably a period of several weeks or even months where your brain is plastic and your brain can change and your brain can recover. And so it's during this sensitive period of plasticity that we really should focus on rehab therapy and recovery to improve people's function and to get them back to where they want to be as soon as possible. I apologize, there's some construction going on, so if it's loud, that is what's going on over here. So in summary, the greatest amount of stroke recovery happens over 3 to 6 months. We still think that's true. I tell people to give yourself at least a year after your stroke, because I do see people improving their function up to a year or even longer, to be honest, if you stay active and do exercises. But the most recovery happens in the first 3 to 6 months. Stroke recovery really happens in a predictable pattern, especially when you talk about motor function or movement. And so that's that work of Twitchell that says big movements to little movements, proximal to distal movements, synergy patterns first, isolated joint movements later. And that is really how people tend to get better. Rehabilitation and exercise increase the recovery of strength. And I didn't go over the research for that today, but we really do know that what you do after a stroke matters, and the more you're able to do, the more you recover. And without rehabilitation or exercise, recovery is slower. So things still happen, things still move, but if you don't do anything, you're probably making that area in your brain smaller that represented that part of your body that had the stroke. Either way, and this is kind of the kicker, spasticity can develop and really should be treated medically, because like we showed in that curve, if you get stuck at spasticity, we don't know what movement you might have underneath there. We don't know what your potential is, because we really need to treat that spasticity so that you can discover to see what kind of movements you might have. All right, so that is stroke recovery in a nutshell. It's a lot of information, but I think it's really important because it sets the scene for some of the medications and treatments that we'll talk about. So first, I was going to talk a little bit about motor strength and recovery. From a medication perspective, this is a conversation about SSRIs, which are selective serotonin reuptake inhibitors, which are basically a class of antidepressant medications. So there was a thought back in 2011, the FLAME trial came out. So this was fluoxetine for motor recovery after acute ischemic stroke, or FLAME, which was a randomized placebo-controlled trial. So it was a research trial that was published in Lancet Neurology in 2011. This study basically looked at standard of care physical therapy, and then they added an SSRI, fluoxetine, which is an antidepressant. The combination of the two increased motor recovery as evidence on that Eickmeyer score that we talked about at 3 months, more than people who just got physical therapy. So this was a really big deal when it came out. I remember when it came out, we were all very excited. The thought was that increased serotonin might enhance neuroplasticity. And so everybody went on SSRIs who had a stroke. The side effects of those drugs tend to be nausea, vomiting, GI upset. Sometimes it can decrease your sodium levels in your blood and cause something called hyponatremia. So we have to be very careful and monitor labs when people are on these drugs. But in general, they're pretty well tolerated. And so this was kind of the start of putting a lot of people on these SSRIs for stroke recovery. A couple of years later, in 2019, the FOCUS trial came out. And so the FOCUS trial was the effects of fluoxetine on functional outcomes after acute stroke, or FOCUS. And this again was a research trial that came out in the Lancet. They basically followed up and did a bigger study with more patients. They had everybody do physical therapy, and then the treatment group, they gave fluoxetine, which is an SSRI, and they followed them up to 6 months. Now, they used a different scale, which is called the modified Rankin score, and it's a different type of scale. It doesn't really measure motor recovery the way Eickmeyer does, which is an impairment scale. Modified Rankin measures what we call disability, which is the ability to kind of do your normal daily activities. So it's a little bit less of a sensitive scale. Nevertheless, their findings were at 6 months. It didn't really make a change on the modified Rankin score. And so it kind of brought into question, should we use these SSRIs? However, the people on the trial did say that it might treat post-stroke depression, which is really an important topic that I'll talk about a little bit later. And they found, when they followed this larger population, that more people had bone fractures, like unexpected bone fractures with taking these drugs. And so that was a risk. So this was kind of disappointing, I think, for several of us who had been prescribing SSRIs after stroke, because we don't want to cause fractures in our patients, and we don't want to give you something that isn't going to help your disability. So this kind of led a lot of people to wonder, well, now what should I do? In 2021, the Affinity trial published results following a population of people up to 12 months after stroke. And so this was the 12-month outcome of the Affinity trial of fluoxetine for functional recovery after acute stroke. This was published in the Stroke Journal. Basically, they said again that the SSRIs do not decrease disability as measured by the modified Rankin score. They followed them at 6 and 12 months and really didn't find a difference in the groups. Again, they said that it may treat post-stroke depression. And interestingly, they followed these patients out to 12 months and did more patients and found that after all, there actually was not an increase in bone fractures. There was not an increase in falls or seizures, and that the drugs were very well tolerated. They just didn't really do anything for the disability. So again, this was a little disappointing for those of us in rehabilitation because of course we want to decrease disability. But I don't think the story stops with these two trials. Because what I want to share a little bit of information about is depression after stroke. So depression after stroke is really common. So it's about 3 times more common after stroke than it is without having a stroke. So within the first year of stroke, 25 to 44% people prevalence will report depression. Within the first 1 to 3 years, this number sticks at about 30%. And all the way up to 5 years, the number sticks at about 30%. So 1 in 3 people who have a stroke may have depression. And that's really important. So the risk factors for depression after stroke are stroke severity. So if your stroke is more severe, or you have a lower level of function, or your cognition was affected from your stroke, you're at a higher risk of having depression. The other big risk factor that comes up a lot is the number of social ties. So not necessarily being married or having kids, but just having certain people in your social support network. The more people in your network, the less likely it is that you're going to be depressed. But if there aren't a lot of people in your social support network, that's a risk factor for depression after stroke. So this is a really important topic. There are different ways to assess for depression after stroke. The Patient Health Questionnaire 9 is very commonly used in doctors' offices. The Geriatric Depression Scale is sometimes used for a little bit of an older population, but there are ways to screen for this. And the most important way is that your doctor asks you about it and you tell them when you go see them in clinic. And I think it's really important to note that depression after stroke is associated with mortality at 1 and 2 years. So people who are depressed after stroke have a higher risk of dying within 1 or 2 years after stroke compared to people that don't. And it's associated with physical disability. So people who have depression have more disability. Or is it the other way around? You have more disability because you're more depressed. We don't really know, but I think there's an association there that we have to be aware of. For treatment, there are several classes of drugs that are found to be effective. SSRIs, we already talked about. And then another class of drugs called TCAs or tricyclic antidepressants are both effective for treating depression after stroke. And if you treat depression after stroke, it improves your mortality rate and it improves your function. So I think that when I think about using SSRIs after stroke, I don't know if it's necessarily that it helps people recover, but I do think for 1 in 3 patients who have depression, we should treat it, because if we treat their depression, your function might get better and your mortality risk will go down. So that is kind of how I interpret all of those studies. And so basically for this topic, when I think about SSRIs or antidepressants after stroke, I still think it might help motor recovery, especially in the first 3 months after stroke. When we use the right scale, which is Eickmeyer, and actually measure impairment, I think it gets better. I don't think, though, that it does help that disability later on at 6 and 12 months after stroke. We've had several large trials using the modified Rankin scale in hundreds and hundreds of people. It doesn't really seem to make a difference at 6 and 12 months, but it may treat depression safely after stroke. So, we talked a little bit about depression. It's about a 30% rate at 1, 3, and 5 years after stroke, which is a lot. And treating it improves mortality, treating it improves function. So what I typically recommend for this is putting people on SSRIs for 3 months after the stroke initially, and then really screening for and treating depression all the way up to 5 years after stroke, and maybe even longer. It's just that we only have data up to 5 years. Sorry, it's so loud. Okay, the next topic is aphasia. So when we talk about aphasia, there's probably two drugs to talk about. One is called donepezil or Aricept. So this study was looking at the efficacy and safety of pharmacological treatments for post-stroke aphasia. It was published in 2018, and this study found that the combination of speech therapy and donepezil improved the ability of comprehension, naming, repetition, oral expression at 6 to 12 weeks after stroke. So the mechanism is that it increases this chemical in your brain called acetylcholine because it's an acetylcholinesterase inhibitor. The side effects of this drug are typically diarrhea and nausea, so a little GI upset can sometimes cause insomnia. In general, it's pretty well tolerated, but we just have to be really careful about like what time of day we give it to you. So I tend to give it at night because it tends to make people a little less nauseous at night. So this drug, donepezil, is used pretty widespread now for aphasia, especially in acute recovery, the first 6 to 12 weeks. There is another drug called memantine or Namenda, same trial, same study reported that speech therapy plus memantine improved the ability of naming, speech, and repetition, again, at that 6 to 12 week mark after stroke. Memantine is an NMDA receptor antagonist, so it works a little bit different in your brain. This one, though, has a longer list of side effects and is not as well tolerated as the other drug. So it can cause headache, constipation, sleepiness, dizziness. In general, not quite as well tolerated. So I really think donepezil, oh, my slides are out, that's funny, my bullet points are out of order here. So I think donepezil might help aphasia recovery in the first 6 to 12 weeks after stroke. It's typically well tolerated. Memantine might help aphasia recovery in the first 6 to 12 weeks after stroke, but it has more side effects. So I typically recommend that if you do have, pretty severe aphasia with your stroke, that we go ahead and try donepezil for at least the first 6 to 12 weeks. So that's 3 months, and combine that with speech therapy. I also think it's worth consider trying it. So if you ever go back and do some intensive speech therapy for your aphasia, or you do an aphasia group or something like that, where you're really going to work on your speech for a while, I will consider putting somebody on it and just see how it goes, because it might give your brain a little bit of the boost it needs while you're doing that intensive speech therapy. I also have some people that just stay on it chronically because it seems to help their speech. We've tried to stop taking it, and then when they stop taking it, they kind of think their speech is worse and they're tolerating the drug well. So we just stay on it chronically. So it's an option. So we're going to talk a little bit about fatigue. Fatigue is a pretty disabling condition. Before I talk about the drugs, I will say that fatigue after stroke is really common. We don't know exactly what the cause is, but I think the most current theory is that the brain is just in recovery mode and it can only handle so much. And so there kind of gets to be a point throughout the day. And for most people, they wake up and they feel pretty good. They go through their normal daily activities and they start to get tired. And then sometime in the afternoon or evening, they kind of just hit a wall and that fatigue takes over. That's pretty normal, especially in the first year after stroke. I think it does improve with time, but it is worth bringing up to your physicians because there might be things that could be contributing to it, like not sleeping well at night, or depression that we just talked about, or something else medical that might be leading to fatigue, like anemia or a vitamin deficiency. If you ruled all that other stuff out, though, there are some medications that we will use, and those medications are the ones I wanted to go over. So the first one's methylphenidate or Ritalin. And so this is actually from not stroke, but traumatic brain injury is where this drug is most commonly used. So this is a study from brain injury in 2015 that showed that methylphenidate reduces mental fatigue and improves processing speed in people who have had a traumatic brain injury. Now, traumatic brain injury is a little different than stroke. But they did use a mental fatigue scale and found that there was an increase of information processing speed at 8 weeks. It is thought to increase chemicals in your brain called dopamine and norepinephrine, which might enhance arousal, so just being a little bit more alert. However, this drug has a lot of side effects, including hypertension, psychosis, tremor, and arrhythmia. And so I think the difference in maybe the traumatic brain injury population could be an age-related difference. And so people who've had stroke in general, not always, because there are young people who have strokes too, but people who are a little bit older who have had strokes probably or may have cardiac issues, high blood pressure. And so this type of a drug is probably not safe if you have high blood pressure or cardiac issues, because it could cause some really bad side effects. Oh, that's so loud. Okay. So the drug that I do think is safe is called modafinil, which is also called Provigil. So this study came out in 2017 in the Stroke Journal, and it looked at modafinil in debilitating fatigue after stroke, and it was a research trial. It found that at 6 weeks, modafinil decreased fatigue on the multidimensional fatigue inventory. It improved quality of life on a stroke-specific quality of life scale. So modafinil is a wakefulness promoting agent. It increases the release of a whole bunch of neurotransmitters in your brain, including histamine, norepinephrine, serotonin, dopamine, anorexin. So a lot of chemicals. Side effects are actually very few. It has very, very limited drug interactions, very few side effects. The problem with this drug is it can be very expensive. And it might be hard to get. So this is a drug that we will try if you're having a hard time staying awake for therapy. But we always have to run the cost through your insurance and your pharmacy because sometimes it's prohibitively expensive. So methylphenidate might help fatigue and cognitive recovery in the first 8 weeks after traumatic brain injury, but the cardiac side effects are typically not very good after stroke because it's like high blood pressure and arrhythmias. Modafinil might help fatigue recovery in the first 6 weeks after stroke, but it can be expensive. So I typically recommend that if you are having a hard time staying awake, like in the rehab hospital for therapy, or even when you leave the rehab hospital, if you're really having a hard time staying awake and we've done all the other medical workup, we can try modafinil. You can consider trying it later on if you cannot stay awake during the days or you're struggling with fatigue. But we really have to make sure that we first look at sleep, nutrition, all your labs, make sure that we're kind of ruled out all the other causes of fatigue first. So the last main topic I wanted to cover was spasticity, and we talked about it a little bit already. So spasticity after stroke, the official definition is velocity-dependent increase in the tonic stretch reflex or muscle tone. Basically what that looks like is your reflexes are very, very excitable or jumpy. You know, when somebody taps on your knee, your leg just doesn't stick out, it sticks out and starts shaking. It's spasms, that's spasticity. It is one component of the upper motor neuron syndrome, which is the results of a stroke or a brain injury or spinal cord injury. It affects about 25% of stroke survivors, so 1.5 million people in the United States. And about a third of stroke survivors report that it is problematic for them. So it's not everybody, but in those people who have it, about a third of people say that it's problematic. So spasticity management is a whole nother topic, but I just wanted to mention it a little bit today. In general, there's kind of 3 ways that we manage it, and it goes through these on the graph. So the oral spasticity medications are baclofen, tizanidine, tizanidine, dantrolene, and diazepam. And you can see in this figure where these drugs act. So they're mostly at the spinal cord, but some of them do act on the brain. Then we also have botulinum toxin injections, which is a toxin that we inject into the muscle. And then we also can give baclofen intrathecally, which means into the spinal cord. So we drip the medicine directly into the spinal cord through a catheter. Dantrolene is the one medication that works peripherally at the muscle and not at the spinal cord or brain level. So these medications, I usually think of them in a table. So what's the medication? Where does it work? what is the indication, like what population do I use it in? And then what are the side effects? Because this usually helps us pick the right drug for the right patient at the right time. So baclofen works mostly at the spinal cord level. We use it a lot in stroke. We use it a lot in spinal cord injury. It can be sedating, and that's the major side effect. Tizanidine also works at the spinal cord level. We use it a lot in stroke and spinal cord injury, and it can be sedating. This drug can affect your liver enzymes, and so your doctor needs to manage and monitor your liver enzymes over time to make sure it's not affecting those. Dantrolene is the one interesting drug that works at the muscle level. And because it works at the muscle level, we use it in stroke and brain injury because it is not sedating the way the other two are. And so it's a really good option. You do have to monitor liver enzymes though, so that is something to be aware of. There is a drug called diazepam or Valium that has been used for a very long time for spasticity. It works, however, at the brain and the spinal cord level. And so the indications are very unclear because the side effects are pretty serious. So it can cause not just sedation, but also addiction. And it is really hard to get people off of this drug. It also interacts with a lot of other medications and can have some really serious side effects, especially if taken with opioids. So we don't typically recommend diazepam, although for some people it's the only thing that works for them. These are the other two options. So I just wanted to show a picture, and I know you've had talks on Botox injections, botulinum toxin injections. That's the picture on the left. So that just shows you an injection into a muscle. We're assuming it's botulinum toxin in that syringe. We do this for stiff spastic muscles in the office. It's pretty common. And we're kind of looking at other options and other things to inject over time that might reduce the frequency of injections. Currently, Botox, you have to come in 4 times a year and get it done. And so we're trying to find out if there's something that might last longer. So more to come on that. And then the picture on the right is what an intrathecal baclofen pump looks like. And so the pump is implanted surgically inside the abdomen. The pump delivers baclofen through a catheter. And so there's a pump in this little packet that pushes medicine through the catheter, up the catheter, its thread up the spinal cord, and then the medication drips out onto the spinal cord and provides relief from spasticity. So the summary for spasticity is these drugs might reduce spasticity anytime after stroke. We use them acutely, we use them chronically. They're mostly sedation, and they can affect some lab values. Diazepam, like I mentioned, can be addicting, so we don't recommend it typically. And then, of course, there's other options like injections or pumps for spasticity. So I typically recommend oral medications only if spasticity is interfering with sleep, function, therapy, or causing pain. So you don't have to treat it. But if it is interfering with those things, then it can help you continue your recovery from spasticity. And of course, there's other interventions if the oral medications don't work. So that is basically it. So that was a lot of information. Are there any questions from the group about some of the medications that we use for stroke recovery?